Good afternoon, and today we are going to talk about the application of osteopathic manipulative medicine for the respiratory patient. Some of our objectives for today: we're going to describe the primary areas of potential somatic dysfunction in the respiratory patient and how to address them. Also, we're going to explain some of the biomechanics of respiration and how somatic dysfunction can change and affect chronic disease and how it may alter optimum respiratory efforts. We're also going to discuss and review osteopathic research that has been done in the respiratory patient, and then also create an appropriate OMT approach for the respiratory patient. When we're talking about respiratory patients, we're talking about patients that have asthma, COPD, pneumonia, also people that have acute respiratory decompensation, which can happen for those that have pulmonary fibrosis, those who are in motor vehicle accidents, etc., and then also your cystic fibrosis patients. Respiratory disease prevention is the number one thing that you would like to happen. Standard approaches to respiratory disease prevention focuses on providing good, clean air and water. If you have somebody that's in a toxic environment, constantly breathing in toxic fumes, that's going to affect the lung. If they're constantly taking in poor water sources, then it's also going to affect the immune system overall. The osteopathic considerations also focuses on adding the respiratory circulatory model, which enhances the host response against pulmonary related diseases. If the environment itself is not conducive to healing and the body is already compromised, then an individual's impaired medical conditions can then be exacerbated. If the ribs are restricted, then the breathing will be reduced. If the diaphragm itself is not moving well because the rib motion is constrained, then your lymphatic drainage will also be compromised. Therefore, the ribs are out of place, your diaphragm is restricted. These are not good environmental situations for the body in order to continue to heal itself and to operate properly. If you have an inefficient lymphatic flow, then this can also result in acute or chronic respiratory infections and other chronic respiratory diseases such as asthma and COPD. Some of the background and the research that has already been done in the respiratory patient. You have studies that were done from the 1918 flu epidemic. The research showed that if the patient was treated with OMT, their mortality rate was 0.25%. If they were treated only with conventional therapy, then they had a mortality rate of 5%. So it was more beneficial and your mortality rates improved when you used conventional treatment along with OMT. Wheatley et al. Also found that rib raising improved the pulmonary function of all patients, but most significantly in the asthmatic patient. And Bradbury et al. Found that when you use OMT to the diaphragm, this decreases the residual volume of the lungs, thereby enhancing overall lung function, which is a key component to maintaining homeostasis. This is very important for those COPD patients who already have expanded lung cavities and their diaphragms are depressed and restricted because of their overall disease. When you're talking about the respiratory patient, you want to also take a look at their Chapman's reflexes. If you have a patient that comes in, some of the reflexes you want to check out is, do they have problems with their lungs, or is it an upper respiratory issue coming from the HE and T section? When we're talking about viscerosomatic reflexes, this is associated with somatic dysfunction referral. So put simply, you have somatic dysfunction that's referred from the organ that's affected, so the viscera, to the bony or the somatic counterpart via the somatic afferent nerves. As you can see from the schematic from Savarese, it's a very simplified version of how the afferent limb transmits the sensory input, and then it gets processed and then transfers to the motor limb of the efferent component. And so with this particular reflex, you're seeing from the organ itself back to the corresponding bony portion. For Chapman's reflexes, we have posterior points. In the lungs, you're looking at T2 to T7. And then for the head and neck, H, E, and T, you're looking at Chapman's points that are T1 to T4, meaning you go to the spinous process and just go lateral at the T7 segment, and you can follow it all the way up to T2, and if you have tendon points there, those are some of your Chapman's points that you're going to find in your lung patient. Anterior Chapman's points For your lungs, you're looking at your intercostal spaces of ribs 2 to 4. And then for the HE and T portion, you're going to look at ribs 1 and 2, the clavicle, and then the sternum. When we're looking at our autonomic considerations for the respiratory patient, look at your sympathetics, primarily sympathetics T1 to T6. When you're looking at the sympathetics, some of the things to consider: if they get overstimulated, you're going to have vasoconstriction of the vessels, which then decreases nutrient supply to tissues and decreases the overall lymphato-venous drainage system. If you also get an increase in goblet cells, this can cause a thick, sticky epithelium and can also decrease the mobility of the mucus. So the mucus can actually get stuck in the lungs or even in the overall respiratory system. Increased sympathetic activity also can inhibit secretions, which then causes dry, cracking mucosa, or nidus, which leaves room for bacterial infections. When talking about the sympathetics, we also have to do the consideration of your parasympathetics, and most importantly, your cranial nerve 10, which is your vagus. Promoting this parasympathetics, this helps to promote clear, thin secretions and eases the clearance via the cilia. However, if you have too much parasympathetic activity, this can cause bronchoconstriction via smooth muscle contractions and therefore decreases air conduction. So it's very important to have a balance between the two. In our standards for osteopathic treatment of the respiratory patient, some of our standard protocols for osteopathic treatment in the respiratory patient focuses primarily on correcting the Zink pattern, or common compensatory pattern as it's also known as, balancing the parasympathetics and the sympathetics, maximizing the thoraco, abdominal, and pelvic respiratory circulatory pumps, so making sure those abdominal, pelvic, and thoracic diaphragm are open, and then augmenting physiologic pumps by doing rib raising, pectoral traction, and Miller or pedal pumps. Whenever you have your respiratory patient, the very first thing you need to do is an assessment. Not necessarily an osteopathic structural assessment, but maybe your very first assessment needs to be taking some vitals, possibly doing labs, including do they need to have a strep test, looking at x-rays if you have a pneumonia patient, are their lungs congested. So make sure you assess your patient first, taking simple history, figuring out where you need to go. Also, while you're doing that history, then you can actually observe the quality of respiration. If the patient is not breathing down to the pubic symphysis and or are using accessory muscles, that means they have decreased quality of respiration. The first thing you want to do is look, are they breathing down to the pubic symphysis? If they are not breathing down to the pubic symphysis, then there's something that's restricting their breathing. The other thing is, if you see somebody that is using accessory muscle usages, this is actually a late sign, which means that person is now in respiratory distress. Checking out their rib cage and their sternum. You want to palpate for somatic dysfunctions, but you also want to look for visual as well as palpable evidence of tissue texture changes. If you're looking at your patient and you can see that one side has better excursion than the other, then you need to remember that side that has decreased excursion, there's some sort of restriction that's going on, whether it be because the ribs are not moving or the diaphragm is restricted, or it could be simply that one side of the lung is not filling in as well as it should. For our respiratory patient, medically, things to keep in the back of your mind. Do I need to give them steroids? Do I need to give them a nebulizer treatment? Or do they also need antibiotics? Very commonly, our COPD patients, we do give them zithromycin, not just because it's good to help fight off infection, but it's also good for decrease in inflammation of the lungs as well. And then after you assess your patient medically, then you need to also take a look at them osteopathically. You're going to look at their Zink patterns, their Chapman's points. You're going to perform any of the augmenting techniques to help improve their decreased pulmonary mechanics that they have developed. When looking at our Zink patterns or our common compensatory pattern, some of the things that you need to take in consideration is that you can correct the uncompensated pattern with either HVLA, muscle energy, BOT, or even myofascial release. It does not matter how you correct it, you just need to correct it. When we're talking about our compensatory patterns and our non-compensatory patterns, the compensatory patterns are common starting from the diaphragm. We have our right, left pattern, or our left, right pattern. The left, right is more of an uncommon, but it is a compensatory pattern. So this is okay. However, when we're looking at our non-compensatory patterns, we're talking about the pattern and how it'll go right, or even left. And that tells us that this is not compensating well, so there's something there that's most likely inhibiting the compensatory pattern. Our thoracic inlet release. When we do our thoracic inlet release, you can correct this with BLT or myofascia. This can also be done while the patient is on a nebulizer treatment, because you can do this particular treatment in the upright position. So this is nice if you have a patient that's in your office or in the ER and they're on a nebulizer treatment. You can do this very quickly, and this will help to open up that thoracic inlet, and then once your inlet is open, then you're able to get increased lymphatic drainage, and you can also help to get that medication more so to the lungs where it needs to go. Cervical correction. Don't forget the cervicals. Remember, C3, 4, and 5 keeps the diaphragm alive. Use muscle energy, cervical HVLA, or BLT in order to correct the somatic dysfunction. Your treatment of choice also is dictated by the patient and the severity of their particular illness or their particular disease that's going on. One thing, if you have a buddy or an extra set of hands that you can use, one thing that you can do is have one person on the cervicals doing soft tissue or BLT, while the other person is down at the diaphragm doing a diaphragm release. This is very nice because it's very evident that you can feel the changes that your partner is doing to their particular region. And so this also, if you're on the cervicals and the diaphragm, working them together actually helps the treatment go a lot faster. And it is something that's very neat, and you can feel the changes right away of what your partner might be doing in the other area. Pectoral traction. This is very nice, gentle technique, and you're applying pressure at the superior portion of the axilla, and what that does is that it opens up the chest wall. This allows further expansion of the lungs and improves overall lymphatic flow. Redoming of the diaphragm. When you redome the diaphragm, this helps to augment breathing. When you're augmenting this breathing, this is by improving the motion of the diaphragm. The diaphragm is a primary respiratory muscle, so you need to make sure that this is working properly. This particular technique also helps to increase lymphatic drainage as well. Then this is also your diaphragm release. When you're doing your diaphragm release, this is more of a direct myofascial technique because you're placing the thumbs just medial to the portion of the ribs that seem to be restricted, usually in that 6 to 10 region. As the patient is breathing, they take a deep breath in, and then on their exhalation, your thumbs will follow and maintain that pressure. Even as they take another breath, you maintain that pressure and then follow it even more. This is that diaphragm release, and this once again is helping to augment breathing by freeing up one of the primary respiratory muscles of the body. Thoracic lymphatic release. This is a very nice technique, and we will go over it further in class. But what this does is that you ask the patient to breathe in, and then as they exhale, you follow their exhalation. When they go to breathe in again, you resist their inhalation, and then when they exhale, you follow them again. On their fourth time, when the patient is asked to inhale, you suddenly release the sternum, and what this does is it causes a sudden expansion of the alveoli, which then also creates room. You get popping of the alveoli. They're able to take in more air, but this also helps to improve your lymphatic flow. Rib raising. Everybody loves rib raising, and this is a great technique. Remember, with rib raising, you go to the spinous process and just go lateral, because what you want to do is make sure that your fingers are on that parasympathetic chain ganglia. And so doing rib raising, this helps to improve rib cage motion. It also stimulates the sympathetic chain ganglia, which can help to augment breathing by helping to stimulate the lymphatics to flow. And with the lymphatics are flowing, then you get your immune system going even more. Finally, pedal pumping. When you're doing this pedal pumping, this is very important because this is one of the major techniques to help get your lymphatic moving. When your lymphatics are moving, then you're getting increased blood flow. With the increased blood flow comes increase of your immunity because your B and T cells are able to flow a bit more freely, and then you're able to get those B and T cells to the areas to help fight off this infection. So when we're talking about the overview of the respiratory patient, the primary goal is to augment respiratory health to maximize the respiratory circulatory system. Number 1, assess the quality of respiration. If the patient is not breathing down to the pubic symphysis and or if those accessory muscles are in use, that means there's decreased quality of respiration. And remember, if you see accessory muscle usage, that means the patient is in respiratory distress. Accessory muscle usage is a late sign, not an early sign of respiratory distress. Also, you need to assess, does your patient need antibiotics? Do they need steroids? Do they need a nebulizer treatment? Do they need to stop smoking? Or does mom and dad need to stop smoking around their child? Remember, with your pediatric patients, they're not always the best advocates for themselves, so sometimes you have to do a little bit of digging to make sure that mom and dad aren't smoking around the child, causing them to have increases in asthma and increase in asthma exacerbations. Finally, we also need to look at, when we're maximizing the respiratory circulatory system, we look at Chapman's points. We also look at the posterior thoracics for the lungs, which are T2 to T7. And then our anterior points, which are the intercostal spaces for the lungs, which are ribs 2 to 4 intercostal spaces. Don't forget that C3 through 5 keeps the diaphragm alive. Why? Because that's your phrenic nerve innervation. And if that's restricted, then you're going to have restriction of the diaphragm, which is one of your primary muscles of respiration. Correct the Zink pattern. This is to allow good lymphatic flow. If there's a non-compensatory pattern that has developed, generally that means that there's some sort of obstruction and it's obstructing the lymphatic flow. Rib cage and sternum, palpate for somatic dysfunction. You're also going to look for visual evidence as well as tissue texture changes. Remember, if you see one side of the rib cage has better excursion than the other, that means that the other side has some sort of restriction, and you need to figure out, is it somatic or is it visceral, or is it actually a combination of both? Diaphragm, diaphragm, diaphragm. That is one of your primary muscles of respiration, and if that is restricted, then you're going to have a decrease in your respiratory system overall. Finally, pedal pumping. That's a great way of getting the lymphatics moving, helping to get the system going, get better blood flow. Better blood flow equals better oxygenation. Also, you're pumping out at the lymphatic level as well, because you're trying to mobilize that lymphatic system to get moving to help fight off infection if there's infection that is present. For any of you who are interested, these are some of the references of where I took a lot of this information. If you have any questions, please feel free to ask me, and I will see you in class.